danger, how do we do that?
Oh, so it gets in the ocean, in the areas by Indonesia.
Oh, well, yeah. Well,
Well,
the two different things they've found now, possible options, that we're in need of. One is here, my microphone got it. Do y'all know what triclosan is?
No.
What is triclosan? Anybody remember? And then guys, I didn't put anything up or anything, I got it late last night, I didn't do anything on that, so you all that today, it's fine after this. What's triclosan? Do you might know? Triclosan is the main component in, is the main antimicrobial agent in most antibacterial soaps. It's a really good phenolic compound used for antimicrobial,
no, like the soap and, yeah.
Problem now with it is, A, it's getting into the water supply and they're developing resistance to it. B, 70% of the human population, or the US population now have detectable levels of triclosan in their urine.
Wow.
20% have levels high enough to actually cause bacterial inhibition of growth. That means you've got enough of this stuff inside of your urine now to actually be antimicrobial.
This is like
Wow.
2 years ago though, right?
Nope, this is the thing I just read.
No, it's like, it's from 2000, banned from 2016.
No, that's when the FDA first started.
But now it's still in the system.
What they did is there's several antimicrobial agents, they banned, I think 20 or something of them, and the other few, triclosan's still one of them, they're giving until 2000, I think 20 for them to prove that it's beneficial, not harmful. So it's on the thing, I have to find that paper on that. But no, you can still, I mean, go by the story they want, I bet you everyone else can still have triclosan in it, yeah.
See, it's,
No, I'm
you're
sure,
talking about the Roundup, right?
yeah,
But this is a glyphosate,
yeah, pathogen disease,
but they're linking it to celiac.
okay, they're looking at celiac, okay. Because they have found glyphosate in food products, and they've also found it in most adults' urine as well. But what's the biggest problem with, the biggest thing in the news right now for glyphosate? It's kind of along these lines right here. There've been 2 gigantic jury awards over it, like in the tune of $250 million.
Is it disease that it's causing?
But-
Non-Hodgkin's or?
Non-Hodgkin's lymphoma, they tentatively linked it to non-Hodgkin's lymphoma. Now, the weird thing, let's finish this up and we'll talk about that, because it's interesting for you guys, because, I mean, DuPont swears that they've done more toxicological testing on this drug than this compound than anything else out there. You've only got 2 jury awards. What's the problem with jury awards?
Subjective.
They're so subjective, right? You get the jury, you get the right guy in there, they feel sorry for this person, they're banned. They don't have to get, the burden of proof is much, much less than even in the criminal.
Where are you in this one?
We did initiation, right?
Yeah, we're on common clinical manifestations of cancer. Or right after that, the racing caution.
Okay. So did we do this one? The change in bowel and bladder habits, sword doesn't heal, bleeding or discharge? All right.
You did or another class then?
Huh?
You did or another class then?
No, I think we did. I remember time when we talked about bowel habits and swords, you know, it changes them all. Okay, tissue integrity. And this is one of the clinical manifestations, we're gonna go through these. Is compressed or rid of blood vessels, ulceration, necrosis, frank bleeding, and hemorrhage. What does that mean in English, in terms of cancer? So you're talking about blood in the stool, from colon cancer, you start getting necrotic, you start getting these blood vessels start leaking, sores that don't heal, growth that causes obstruction, bowels, ascites, things like that. But what are they talking about sores that don't heal? Why would a cancer lead to a sore that wouldn't heal? Yeah, not necessarily immunocompromised yet. Could be later on, possibly, you can't do that.
Yeah,
Huh?
that was
If
what
it's
I did.
next to it, the blood is taking an nutrient.
You loss of blood supply, you start getting this necrotic tissue damage. Now, cancer cells can also secrete toxins too, so they can kind of both. But part of it is like they talk about here, tissue integrity. You lose blood supply, you lose oxygen, which causes necrosis, right? And you also lose immunity, you lose that ability to for tissue repair. Ataxia and anorexia is weight loss and wasting of body fat and muscle tissue, profound weakness, anorexia, and anemia. This happens in a lot of cancer patients. 80% morbidity and 20% death in advanced cases are from this alone. Okay? And another problem with this is gonna be what? If you start getting either one of these conditions, you actually have poor response to chemotherapy also as well.
Oh. Why?
Just probably breakdown of it. I mean, they're not even sure why some of these happen in cancer patients. Some of it's loss of blood supply, some of it's the cancers are using up all your nutrients and everything else. Some people, they don't even know why. It just happens sometimes. But basically, it's probably just a mess up of hope metabolic pathway. Chemo trying to work as well.
Mm.
So weight loss, do not, this is weight loss, did I write that right? Weight loss not due to, okay, here we go. So, and that's the problem with this. The weight loss is not due to decrease in caloric intake. That's why I said I'm not sure why some of these things happen. Weight loss in fat and protein, skeletal muscle. So they just call it, you ever heard of wasting in cancer patients, that term?
Yes.
That's what they're talking about here. They just start to waste away and they don't know why. They can keep the caloric intake up and everything else. Now, it can be hypermetabolic rate of cancer, we talked about that, we were talking about that, high glucose consumption, high O2 consumption, but it doesn't make up for all of it. Increased inflammation, so cytokines, one of the problems with cytokines is they can cause appetite depression.
Oh.
So if you have a cancer that starts secreting, or the inflammatory response to the cancer starts secreting cytokines, that can also cause what? A decrease in appetite. So any of these things can feed back to what?
Weight loss.
Weight loss, protein deficiency, things like that, right? One of the things they try and get in cancer patients a lot is start to refuse. They try and supplement with high protein and those, what are those little drinks called?
Those protein shakes?
Oh, yeah, sure.
Things like that, yeah. And then again, fatigue, sleep disorders, and anemia are gonna be the other ones. Most cancer patients have issues with fatigue because why?
That you can
Do what?
be, just using all your ATP.
Everything, yeah, you're not getting enough nutrients, they're not being distributed properly, cancer's using all of it up, it's gonna be fatigue. Also cytokines and things like that get released can also cause you to be fatigued. Sleep disorders, I don't know, I have sleep disorder, I hope I don't have anemia, again, could be from bleeding, it could be from a couple of different, a lot of them are from bleeding. If you have a lymphoma or you have colon, what's one of the main, colon cancer, what's one of the main indicators of that?
Bleeding from your.
Could be anemia, you can get bleeding in there. Now, paraneoplastic syndrome is inappropriate hormone release, circulating hemopoietic, neurological, and dermatological factors, and immune responses, onconeural antigens. Just know what this is. I'm not going to go into this whole thing of paraneoplastic syndrome, but it's basically what? You start getting this weird release of hormones that aren't supposed to be released at a particular time.
And they don't know why that happened.
Not really. And it's kind of complicated when I'm reading through it, so I decided to just know what it is, okay, and think this through. Maybe I'll look into it more. So how do you diagnose cancer? Because diagnosis right now is the key to what?
To beating it.
To survival, diagnosis. The earlier it's diagnosed, the better your odds of what?
Survival.
Surviving. I mean, almost every cancer is curable if you can catch it early enough. Pap smears are for looking for what?
Cervical.
Cervical cancer. Biopsy, what's a biopsy? Why is a biopsy so important?
You can take the tissue and study it.
So what do I study? I can take tissue.
You can do like thyroid, you can do
Did
skin.
you see if it's?
They could see it.
Or
Okay, so it can help you determine whether it's cancerous or non-cancerous. How else could it be helpful?
Where if it metastasized from somewhere else?
We could, if it's secondary tumor, you biopsy liver tumor, you can see where it came from, right? Why else would it be helpful? Treatment, that's a big one people don't think about. Treatment. Different cancers respond to different treatments. So not only do you want to know if it's cancerous, you want to know what kind of tumor it is so you can do the appropriate treatment. Huge in lymphomas and stuff. You have B-cell lymphomas, T-cell lymphomas, dendritic cell, all the different immune cells can be lymphomas, right? But they all respond differently to different treatments. And that kind of goes along with cytological studies and tissue biopsies right here. These can be together. Endoscopic examinations, what would you look for endoscopic examinations?
Damage.
Polyps? I don't know, polyps?
Endoscope,
It's through the throat, right?
Yeah, but what are you looking for?
Oh, this,
Yeah, you can just go gonna be down. What are you looking for?
Same thing, right?
Nothing, not Paul's been damaged, inflammation, damage, ulceration,
Bleeding.
things like that. But they can also do this new one, I don't think I have it on here. It's called, it uses ultrasound, I forgot the exact name for it, do I know? Anybody works in imaging on there? It's an endoscope that also uses sort of an ultrasound, they're using it to diagnose. So if they get down the side of your GI tract, and they can start sending out sound waves, they're using it to diagnose pancreatic cancer. Yeah, a little bit, trying to get a little bit earlier. Of course, that means you gotta go in and have one of those done, right? Well, I think I'm gonna go have one of those done tomorrow, but it's fine.
Well, if it runs in your family, I would think that you would.
No,
Well, we'll
they're
get back to that,
horrible.
some of the issues with that in a minute. Ultrasound does what? Sonography, am I gonna be a stenographer? Stenographer? Wait, is it stenographer? Sonographer.
Son.
Sonographer, right? Yeah, stenographer's a little guy.
They're like, isn't that typing?
So that uses sound waves, right?
Mhm.
X-ray studies, MRI, CT scan, what's a PET scan? If you took my 13.
Isn't that it's like a little bit better than CT now?
Oh, you put your pen in there, you can't.
No, it gets like everything instead of
My little
CT.
dog.
But you talked about it last semester.
PET scan, positron emission tomography.
It's like a newer development.
Well, what do cancer cells use tons of?
Sugar.
Oh, glucose, right? Oh, yeah. They did feed us well on this trip, a little bit. So, lots of sugar. If I want to see if cancer has metastasized
Oh,
anywhere in the body, how am I going to do it? Am I going to go biopsy everything you got? I'm going to take 27 biopsies out of you, all right? So let's see the cancer spread. Every lymph node we're going to go to. What can you do?
Drink the sugar.
Yeah, the drinks, the sugar water thing.
You give them radioactively labeled glucose. If glucose is preferentially taken up by cells to be used as energy. Anywhere that's using tons of glucose lights up like a Christmas tree.
So it's positronic what?
Positron emission tomography.
Emission.
Okay. CT scans, we all know CT scans, right? Tumor markers are the big ones I'm talking about now. This is the big key to diagnosis now. Tumor markers. In particular, blood-borne tumor markers. Things that you can take a blood sample from and find a patient early that has a particular cancer because these tumors are secreting these. They're usually going to be proteins into the blood. What's the only one we talked about they use regularly? Any tumor marker that they use. It actually is kind of controversial. They go back and forth on how good it is. Okay, clinicians out there.
You don't want to be a nurse.
What is the one thing what is this, a blood test they screen cancer for? Huh?
Oh, blood test?
What's in here? You don't-
So a common blood test to detect cancer.
What is a blood test you all have heard of they use for screening cancer?
Wouldn't it be like STD panels, maybe? Like for HPV?
Nope.
No? Okay.
That was a good guess.
So is it on a regular blood test?
No.
You have to look for a specific?
You have to ask for it. Only 50% of the population is gonna be any good for it.
Is it a protein or is
That
it?
should give it away right there. Huh?
Ovarian,
What?
ovarian.
No. That's CA 125, we're gonna talk about that one. CR 120 CT, so I can't remember. No, I just got the name of that one. That's not it, though. That's a controversial one. What's another one?
Like the leukemia? Like
Nope.
the elevated lymphocytes?
Nope, that would be later on if you suspected leukemia. You might see that in the blood test, but it's not one that's specifically designed for that yet. A lot of flow cytometry for that, and things like that. Come on, people.
Is this easy?
This
Like,
means
or
that
is this
when
because
he
you have a
said-
PhD and you know?
No!
Okay,
You
because
said
I.
50% of the population asks for it, right?
Okay.
No.
So it's either a
No,
man or
how are we
woman
gonna
thing.
work in 50% of
It's gotta be
I feel
like a
you
man
talked
or
about
woman
this
thing.
recently.
So it's gotta be male or female, okay?
Yeah.
Throw that out. I can't help it.
Prostate specific antigen.
But,
The prostate specific.
thank you, very good.
Yay!
Prostate specific antigen, that's it right there. That's the one. Prostate cells start to secrete this thing in solution. In general, the bigger the prostate it is, the more that you secrete. But what is the problem with the test? What can you all think of when putting in the problem with the test? Because now they go back and forth. 2 or 3 years ago, they said it was a terrible test. A lot of doctors would quit using it. Guy I went to last time, I was talking to him about it, he goes, oh no, I still like using it. I'm like, okay, you're not the only one I know, but anyway. He said it's good for something else. Why would it be a bad test for diagnosis?
Cause it's majoring.
Measuring a secretion of a soluble antigen from your prostate, and generally the prostate gets bigger the more it secretes.
Mm-hmm.
What do you see the potential problem with that? And it has shown to be problems.
A false negative or a false positive?
False positive.
Positive, okay.
Hmm?
The specificity.
No, it's not too bad, specificity, sensitivity's not too bad. But, so why else would you be getting false positives? Because it's not just of the test, false positive test. I mean, it would boil down to, it would boil down to specificity.
Is there
Problem is, a lot of males go through what's called benign prostate hyperplasia when they get older. BPH, you ever heard of that thing? Okay, look, if you get older, the prostate just gets bigger, you start doing secreting more what? PSA. If you have to have an infection of the prostate, you start secreting what?
More PSA.
More PSA. So the question is, how good of a test? You get these fluctuations. What they're trying to do now is get a baseline and then see how much
So
fluctuation.
it'd be like an issue with validity.
Yeah, well, yeah, but it's not of the test itself, it's of what it's detecting and the reason why it might be like that. What is that one for ovarian cancer? It's 125, what is it? Let me get back to that in a minute. What staging and grading of tumors?
Oh, that's when they tell you it's like stage 1, stage 2, and how aggressive it is
Right, why is that important?
to see how to treat it.
Not only see how to treat it, but what else?
See if it's spread.
See where it's spread, how soon, how far along is the tumor? Stage 1 is where?
Local.
Early stages.
Still localized inside of the main tissue. Stage 2 is started to invade neighboring tissues. Stage 3 is moved out into sentinel lymph nodes, neighboring lymph nodes. Stage 4 is metastatic, it's gone elsewhere in the body. Now, screening for the detection, observation, palpitation, and laboratory tests. What is observation? Give me an example.
Like if the mole grows or changes color or size.
Mm-hmm.
Visual.
Visual palpitation.
Like you feel it?
Yeah, feel like that. So that would be what? That could also be mold, that could be breast cancer, that could be what else? Swollen lymph nodes, a big one, anything else, anytime, any swollen, even you can palpate for what? Pain as well, and everything else too. Although, do most cancer cause pain initially inside of an organ?
No.
Why not?
They're not pressing against any nerves,
It's an organ.
pressing
I
against
don't know,
any.
because I know they tell you that also for any painless lungs.
Yeah. So what about nerves though?
It's not pressing against anything.
Inside of a tissue, inside your liver, let's say,
Mm-hmm.
or your pancreas? So why does it hurt later on?
But it's wrong.
Okay, so why?
And it's in your lymph nodes or it's in your.
Because when it's dividing, it hasn't, it's not even detectable till it divides.
But why?
Is it because it's more releasing more like
What?
cytokines
Good,
or I don't know?
Most of your soft organs do not have pain nerves inside of them. The pain is in the capsule that surrounds them. And you usually don't start feeling pain until the tumor gets big enough to start stretching that capsule muscle. You made it right there. Laboratory tests, again, we talked about those could be any of these on the other side, right? Imaging, biochemical tests, cytology.
Psychology.
Alright, psychology.
Are these-
Tumor markers, diagnosis, progression, and reoccurrence, elevated benign conditions, but not in what? So these are some of the problems with some of these tumor markers right here. Benign tumors, if you have benign prostate hyperplasia, I just talked about, that's still a tumor, right? It's overgrowth of tissue, and it's gonna be producing those PSA. The biggest problem with other markers, things like prostate, pancreatic, these other ones, is they don't start secreting them in big numbers until they get big. So that's the problem. Pap smear, tissue biopsy, what's immunohistochemistry?
Whoa.
Is it a type of test?
Well, talking about tissue biopsy, everybody knows what pap smear is, right? Guys, y'all know what pap smear is? Just text you. What's immunohistochemistry? Why would it be important?
Of blood?
Immunohistochemistry is where you're gonna take labeled antibodies, and let's say you wanna look for a particular cancer in a tissue, you can take that tissue, small amounts of it, and then you can add those antibodies to it. And if it's got the cancer, the antibody's gonna do what? What do antibodies do?
Bind?
They tag things, so they're gonna stick to that cancer tissue, and they're either gonna fluoresce, or they're gonna change color or something like that. But it's a laboratory test you can use to detect small amounts of cancer cells, especially if you use fluorescence. It's like, flow cytometry. Does everybody know what flow cytometry is? That, I'm gonna mark the place. What's flow cytometry?
The like serology kind?
A flow cytometer is you have this instrument
It's-
here.
The one that flashes?
I'm gonna bring that up, hold on. So these are getting cheap enough where they're gonna start showing up in hospitals and places. So you probably need to get. All right, right there on the board, nice big picture. All right, so flow cytometry, you've got PMTs here with stuff for photomultiplier tubes. They just detect light, don't worry about what they do. You've got your cell sample here, it's gonna bring down the sample and the nozzle's gonna put it through a tube, one cell at a time. Okay? Does that sound familiar enough for micro?
Yeah, it flashes, right?
Huh?
That's the one that flashes, right?
If you're
That's what I
gonna, so
said.
if you're looking for leukemia or something, you can put an antibody in there that's only gonna attach to leukemia, that's gonna have a fluorescent tag on it. Every one of these cells come through here. If this one has got it on there, and this one's got it on there, as soon as they go through there and get hit by that laser, what are they gonna do?
Flash.
They're gonna light up, so you start counting the number of cells. You also count the number of cells that goes by, but now you can also count the number of healthy cells versus what?
Okay.
Cancer cells. So you can also use this to look at what, aside from diagnosis, what would this be useful for?
The stage.
Staging, well, lymphomas are a little bit harder to stage than leukemia blood cancers, but what else could you use it for?
Treatment.
Treatment, you can see how effective the treatment's been. If the treatment's being better, the number of cancer cells should do what?
Decrease.
Start going down.
Wow.
See, these things used to be huge, but this thing, we got a tabletop full of pallets of them. That's the one I used to work on, something.
Wow.
And that was about, $500,000. All right, microarrays. Microarrays are where you actually start looking at changes in gene expression. You're actually looking for those mutations, okay? Does this cell have this particular mutation in it? So you take all the genes out from the cancer tissue, you put them in these little slides, and then you mark them again with, you mark them so you can tell if it turns one color, it's got the mutation, if it turns another color, it's the healthy gene thing. That's all those are used for. But you can screen up to 20,000 genes on a single microarray. Why would that be important? Why would be knowing what gene, this is gonna be big for you guys.
Do you see the cause for treatment?
The progress?
Well, where it started from, if it was from the change, the whatever pathway it missed.
Okay, so-
Checkpoint it missed.
Well, sort of, yeah, kind of you're backing up, then so that you check where you're close. A lot of these things called targeted therapies now are going after the mutation, what the mutation is causing, so you're kind of right there. So that's what you can, you can look for it and see, do I have a mutation, or KRAS, or JAK-STAT pathway, or any of these pathways. Now, these targeted therapies can go after those particular pathways in general, they're a lot less toxic. So that's what microarrays is good for. All right, goal for cancer treatment, curative, control, and palliative. Curative, do I have anything right? What does curative mean?
To stop it?
Cure it, you're gonna get rid of it, right?
There, yeah.
So, curative treatment modalities, surgery, curative prevention. Radiation does what?
Targets it.
Okay, surgery is gonna be curative. Idea is if you can cut it out and get rid
Doesn't
of
radiation shrink it or break it up?
it should shrink the cells down, it should kill, ideally you should be able to kill them, but the problem is with stem cells, we talked about, they're not responsible to it. This usually, hopefully, is curative. It can be preventative in what? How can it be preventative? So curative makes sense, right? I got lung cancer, I take the lung out.
Well, preventative, like when you get a double mastectomy before you get the cancer.
Right, something like that. And some guys go through prostate cancer cure and some things like that too. Also, how about colonoscopies? Would that fall into this category?
Poly.
Yeah, you're removing polyps, things like that, anywhere else. Great answer about what's hormonal therapy? 2 examples.
Yeah.
Somebody want to teach 1106 lab?
Well, like if you take somebody off estrogen and progesterone, or you don't keep them on both at the same time, they can get like polyps and stuff like that, or not polyps, but growth in their uterus. Or
It
their,
could be. What's the more direct example of 2 different hormonal treatments
For cancer.
for cancer? Add this in, you've already got it.
Oh, my mom had to do
So this isn't gonna be,
after they say you already have it?
already got cancer. Think about 2 different, okay, what cancers are hormonal treatments gonna be effective for? That's, you should be able to narrow it down.
Thanks, the cervix.
Cervical maybe, could be ovarian for sure, breast cancer definitely, right?
that. Yeah.
And prostate cancer in males. Any of the ones that are hormonal related cancers that cause them. Cervical. Look at that one. That's usually, I need to look at that. Anyway, the key to, I'm really talking about breast cancer and prostate cancer. First line of treatment for prostate cancer is DHT attaches to the androgen receptor that causes growth. You block the end, it's called androgen deprivation therapy. You prevent testosterone from getting into the prostate cancer and binding to the receptor, it shuts down growth. That's what we're talking about. But when it gets bad, you don't need that testosterone anymore. Breast cancer, a lot of them which are ER positive, which is what? Anybody know? ER positive
Estrogen
breast
receptor.
Estrogen receptor positive breast cancer.
Yeah.
Estrogen's gonna bind to the estrogen receptor, it's gonna cause proliferation. So tamoxifen does.
Tamoxifen. I knew it was a T. Damn it.
Tamoxifen blocks that. It's an artificial agonist that blocks these things, okay? Targeted therapy, we just talked about. Targeted therapies are targeting something that has gone haywire in the cancer cells, not just killing fast dividing cells. You go after p53 mutations, you go after KRAS, you go after tyrosine kinases. I'm not want you to memorize all these things, but they go in there, they find out what mutation is causing the overgrowth, and they try and target that individual pathway. Because those shouldn't do what to other cells. Should that damage healthy cells? No. This is the big one right here. Here, and then here. These are gonna be the 2 new gold standards for targeted therapy. Targeted therapy, cancer therapy. Targeted therapy, and then immunotherapies. Okay. I want to go back to immunotherapies. Yeah, I go through. All right. I forgot I put these in. We'll go through these one at a time. So chemo just does what? We'll go through each one of these. Direct DNA interacting, indirect DNA interacting, cell cycle specific, and cell cycle non-specific. And I've got these, we go through these individually. All right. So cryosurgery, what is cryo?
Freezing.
Freezing. They take it in there, they try and freeze a tumor. What's a good reason for that? Stop the growth, but that's anything, but what's kind of a nice thing about cryo?
It doesn't affect all your cells.
Yeah, it can damage some around it, but it's pretty targeted, pretty much it gets relatively secure. Cryotherapy, it works on some things, prostate tumors and some other ones. What's chemosurgery? A lot of people don't know about this much. Use this on some benign tumors. What is a classic example of chemosurgery?
So when it has it.
Using corrosive paste with multiple frozen sections to ensure complete removal of the tumor. The second part is you're making sure you got rid of it. How about warts? If you put something on a wart, wart's a benign tumor, right? If you put something on there that's going to dissolve the wart, what are you doing? Most of those are what? Actually, corrosive paste to get rid of these tumors.
I thought that would have been cryosurgery. That's what I would have thought.
They do cryosurgery too, for warts too, but they also use paste and stuff like that. I don't know, you don't see much about warts anymore. They used to have it on TV.
So that's when they haven't crossed the basement membrane or anything, or they're staying.
Yeah, they just stay inside of it. Now, you can use it for some other ones too. The problem with metastatic tumors, they're growing kind of fast. These can take a little bit of time. Laser surgery is just what?
Like burning it
Using
off?
lasers to burn out cut off tissue. And laparoscopic surgery is what?
Like the another robot?
The machine.
Can be a robot, doesn't have to be a robot. Laparoscopic surgery, they fill
Like
up your abdominal
gallbladder.
cavity with saline and they punch two holes inside you and they stick those into there.
Like gallbladder removal.
Yeah, gallbladder. My knees are done on laparoscopic, they do all back, their laparoscopic. Alright. Oh, I didn't go through more of those. Here's a minute. Yeah, sorry. Stem cell transplantation, bone marrow transplantation, peripheral stem cell transplantation. These are what? These are only gonna work for what?
Blood.
Right now, they're mainly going after leukemia in some folks, right? Because leukemias are blood cancers inside of the bone marrow. Whole body irradiate them, you kill off all the bone marrow cells, you put new ones in. They are looking at doing certain solid tumors and other cancers, by sort of putting in these stem cells that they're training to go after the cancers. They're gonna be immune cells. So we'll talk about those in a minute. This. Radiation we talked about a little bit. Radiation therapy uses high energy particles to destroy, just tear up the DNA. But absorption of energy from radiation tissue leads to ionization of molecules. It shreds the DNA, it causes DNA adducts, it just kills it, hopefully. But radiation can also produce what? This is talking about more about the microwave. So radiation can also produce effects directly by interacting with water. They use microwave for this, okay? So you can produce free radicals, you can heat it up. But what's the downside of radiation therapy? Don't have.
It damages like what it's besides its target, but it also damages.
Yeah, okay, I've got it. I'm sorry, guys. Let me go through this. So, let's just go through radio sensitivity. Let's look at these right here. Because we all know how radiation works, right? How does it work?
It damages the DNA.
Damages the DNA, protein, ionization, things like that. It's going to damage stuff. Radio sensitivity, certain cancers are more sensitive to radiation than other ones. But what is combination of chemo and surgery? External beam radiation, that just means it's coming from the outside, right? So what do they mean by palliative also? What does palliative care mean?
Just to make them comfortable.
Right, so if you're in palliative care, that means what?
You're good night.
You're gonna die.
Yeah, it's just to make you comfortable, you can try and shrink the tumor. But when do they use a combination of chemo, surgery, and radiation?
When they cut
Because this
it.
is actually changed now.
When it's like a certain stage, isn't it?
Not necessarily.
How aggressive
Well,
the
they do it to make sure they got it off, because they don't know if it's spread around the tissue.
All right, hold on. They used to do surgery first, right?
Mm-hmm.
Cut out the tumor, and to make sure you got everything, they would give a combination of chemo and radiation to try and kill anything you missed.
Yeah.
The newer protocol has switched that around. Now what they want to try and do is shrink the tumor before they excise it with surgery. So you get chemo,
first.
radiation,
Oh.
shrink it down so you can get clear margins, and then cut the tumor out.
Was that like how you were saying because some tumors have like roots kind of thing, and so they want to shrink it to make sure they
wanna
get
shrink it down,
everything?
make sure they can get everything, because at the very tip of those borders, are you gonna be able to see one or two
Yeah.
different cells?
Yeah.
That's what they worry about.
That's one of them gets spread right with the crowd.
The crab ratio. But they're also, I'm assuming they also give post-surgery chemo, but they're doing it now to shrink them. Problem with radiation is what? It indiscriminately kills,
Mm-hmm.
okay? And the other problem with it is, what do you think the other problem with it is from killing? So tissues of the treatment fields are the most frequently affected on the skin, mucosal lining, the gastrointestinal tract, and bone marrow. So what's a potential side effect down the road from radiation therapy?
Can't it also cause its own cancer?
It can cause cancer down the road, especially in children. You get radiation therapy, you cure a child with leukemia, but then 30 years from now, they come down with something else. Or you treat some other cancer, and 20 years later, you come down with leukemia.
Mm.
All right, I'll try to get through this chapter. Indirect and direct DNA, let's just go through these. Direct DNA chemo agents, interacting agents include alkylating agents, anti-tumor antibiotics, topoisomerases, okay, inhibitors. As a class, the alkylating agents exert their cytotoxic effect by transferring their alkyl group to many cellular constituents. Topoisomerase inhibitors, a toposide is one you guys will come across. prevent those, okay, where does where do you see this enzyme? Topoisomerase.
That's the one that, cancer, that's how cancer grows with telomerase? Is that it?
Look at telomeres, this is gonna be what,
It's different?
that's telomerase, this is topoisomerase. Okay, you guys get ready for your little test this summer, you better know these things.
Oh.
Where do you find topoisomerase?
Is it an organ?
Well, why do you DNA?
Good, it's in front of DNA mitosis and DNA synthesis, thank you. At the very front of it, as you're unwinding it, if you don't cut it and ligate it back together, it knots up, right? You all remember that from
I
1306?
thought that's helicase.
No, helicase breaks the double-stranded bonds and opens it up. Okay, so you've got this going on right here, right? Helicase is right there.
Okay.
Topoisomerase is down here and it cuts here and it cuts here and it cuts here. Because if I get a phone cord and I just yank it apart, what's gonna happen?
Tingles up.
So
It's
it's
gonna
kinda-
knot up on itself, right? So this prevents that knotting.
Oh.
So with the inhibitors, you're trying to get it to not?
No, yeah, that and it doesn't let it reseal back these double strand breaks, so it just starts to shred the DNA or it knots up and it can't replicate. They work pretty well. The anti-tumor antibiotics, these are ones naturally made by bacteria, some of these, the anthracyclines, doxorubicin, daunorubicin. Problem with these two, no, that one. These two is what? Both these have major cardiac toxicity. A friend of mine from high school came down with lymphoma, was misdiagnosed. He had a massive dose of doxorubicin. They cured him from the lymphoma. I think about 10 years later, he was in a elevator in Las Vegas. The only reason I mention that is back then, that was one of the few places that had cameras in elevators. And they just showed him, he just fell over dead.
Wow.
He had a massive cardiac event caused by the damage from the doxorubicin.
Oh, we were just talking about that. So that happens. Why?
Huh?
Why does that happen?
It's got, because these doxorubicin and daunorubicin have very, very strong cardiotoxicity profiles. They damage the cardiac tissue.
Oh, yeah, that's what we were just talking about in the car. Because I had a student, her mother passed away. She was doing better. She had just gotten on remission, and then she passed away from a heart attack.
Right, and that's the problem, is a lot of times they use, and that's the problem with using these drugs. They're very effective, however, you can have to be careful how much you give, because it's gonna depend on how much cardiac damage you're gonna give the person. Side effects acute 2 to 3 days, these are transient, that may be what happened if they just went into remission from that person. Chronic was the cardiomyopathy that he got, and caused cardiac arrest later on. What cardiomyopathy? Quick.
Heart, valve problem? Just kidding. Heart.
The pathway in the heart.
When it's not beating and it's a good rhythm?
AAP students.
Cardiomyopathy. Isn't it irregular, like when you do ECGs, or EKGs now? Irregular beats?
Does it do with dilation?